of diabetes. So with the rising use of technology and IoMT, or the Internet of Medical Things, the evolution of smart devices and wearables, the medical technology industry is on the cusp of a home care revolution. And this definitely creates an opportunity for developing effective, cost-effective solutions with significant potential to reduce the diabetic foot treatment costs, as well as saving limbs. So this presentation will actually focus on the role of telehealth, telemedicine for wound care and diabetic foot management. The pandemic that we are going through has actually pushed us more towards the faster use and the more adaptability towards the use of more technology in our daily lives. Now it's my honor to introduce Dr. Manisha Singh, who is a Associate Professor, Department of Surgery, Gajaraja Medical College at Gwalior. She is a diabetic limb salvage surgeon at Gwalior Diabetes and Foot Care Center. She is an MS General Surgery with fellowship in diabetic foot management from the esteemed Amrita Institute at Cochin under professorship of Dr. Bal. She is presented at various national and international forums. She is a consultant practicing senior diabetic limb salvage surgeon at Gwalior Diabetes and Foot Care Center since 2005. She is presented multiple papers at various levels, the state, the national, and the international. She's also been international faculty to the advanced diabetic foot course in Dubai, as well as she's got the best oral paper presentation at the Asia Pacific diabetic limb meeting at Kuala Lumpur in 2014. And she's also written chapters to the International Textbook of Diabetes by Sadi Court. And she's also hosted our Diabetic Foot Society midterm meeting last year in 2019 at her hometown Gwalior. That is Manisha for you. I welcome Manisha to go ahead and teach us or tell us the role of telehealth or telemedicine for wound care and diabetic foot management. Welcome, Manisha, and welcome, delegates.
Yeah, thank you so much, Srinivas. A very good evening to all of you. And this is the 10th webinar hosted by DFSI. And at the outset, I would like to thank my mentor and motivator, Dr. Bal, for always his support, and Dr. Rajesh Keswan for guidance and his valuable time in preparing this presentation, and all my colleagues and friends for being there as a support for me. So, well, today I shall be speaking on use of telemedicine in The topic of today's webinar is use of telemedicine in wound care and diabetic foot management. So an old, elderly, lonely living patient with a diabetic foot need not depend on or dream of Aladdin's lamp and a carpet to see a doctor or for his foot problem, but he can directly see have a doctor at his doorstep through a device, as a telecommunication device. So broadly, we would be talking about the historical account, overview, the introduction, the various telemedicine practice guidelines, types of teleconsultations, and the various videos, how the consultation goes on, and also the how the triage is done in diabetic foot and wound care for the diabetic foot to telemedicine. So in the early part of the 20th century, the first event in modern telemedicine was Alexander Graham Bell. He made the first telephone transmission to his assistant, Mr. Watson, and said, "Watson, come here, I need to see you." Later, this jump started, and we can dial 101 or 108 or 911 for emergency healthcare services and ambulances. And so telephone has been a kickstart in development of the modern telemedicine. The various pioneers of telemedicine in India were Professor Ganpati, well strengthened by past President Abdul Kalam. And telemedicine in India was first unit came up in the village of Aragonda in southern India. So Diabetic foot ulcers, as we know, the annual incidence is 1.2 to 3%. There's a pandemic or the global epidemic going on in the together, diabetes and COVID together. Globally, 20 million people currently have an active diabetic foot ulcer, 130 million have a history of diabetic foot ulcer, and 4 out of 4 lower extremity amputations are preceded by a diabetic foot ulcer. This means lot of hospitalization, longer stay, lot of economic burden on the patient, and 20% of diabetic patients are hospitalized on account of DU. So telemedicine has emerged as an economic and patient-friendly modality for wound monitoring and care of the patient. Now, where do we stand? WHO recommends a doctor population ratio 1:1,000. With the current population ratio is only 0.6 to 1,000, and deficit is covered by telemedicine. As it is very difficult to train the physicians or the consultants in a very short period of time, it is better to reach out to remote places and to other places with the help of telemedicine. So the escalating burden of wound care has posed an increased risk of amputation for diabetic foot patients and consequent poor quality of life. Again, telemedicine is an enabler of healthcare access, affordability, enhances communication with the surgical wound care specialists, which are only few in number. So we have a Ministry of Health and Family Welfare have created a telemedicine portal, and this connects the various medical college, and also across the India, the healthcare services are connected. So literally telemedicine term translates into healing at a distance. And telemedicine is telemedicine has a natural evolution as in the field of healthcare, in the digital technology, and it is a delivery of healthcare services where participants are separated by a distance for the purpose of diagnosis, treatment, prevention of disease, research, evaluation, and continuing education of the health workers. So in this study, it's a large trial which was done, and the analysis of the various trials, large study was done. And in this meta-analysis, it was found that telemedicine is a promising method of care for the diabetic foot patients, and it was comparable with the usual care which is given while in the hospital or in the OPDs. While telehealth includes, in addition, the health information services and the self-care telecom services, which are, or the patient education services, which are given to the patient in addition to the diagnosis and care. A registered medical practitioner defined under IMC Act 1956 has to be enrolled in a state medical register or Indian medical register under Indian Medical Council Act. So telemedicine can be in the real time by video, audio, or text interaction occurring at the same time, and exchange of information is occurring in real time, and even the counseling is given in the real time, compared to the asynchronous exchange of relevant information which could be accessed as per convenience or need in the real time. And this is usually done by the storage and the data transfer method. So the infrastructure and hardware are just the same as a personal computer normally of the desktop type. Additionally, you can use laptop computer, palm-top computer, PD, or even a dedicated set-top box with the processor. And minimum specifications required for typical PC are those with the standard desktop. So looking at the various modes of communication which the RMP uses to consult, do the teleconsultation, are the video, audio, the text methods, and the telemedicine facilities provided by the apps, video and chat platforms, FaceTime, and it is the closest to in-person consultation occurring in real time, and the patient and doctor identify each other, and the inspection of the wound or the inspection of the lesion and patient examination is a relatively easier and just like face consultation. Limitation is highly dependent upon the internet, quality of internet connection, and possibility of abuse or misuse, or privacy may be leaked, and so especially in the video consultations. The for the audio or the phone is the or the VoIP apps, etc., are the very convenient, inexpensive method occurring in real time. But Here, the visual inspection is not possible. Patient misidentification may occur, and you cannot be even examine the patient or the patient's wound. The text-based specialized chat form can be in the real time or can be asynchronous, and documentation identification is an integral part of this modality of communication. These are very suitable in urgent cases, and however, the healing touch, verbal cues, visual inspection, all these modalities may be missing. A patient may be, the exchange of images may occur, may be there, but the healing touch is definitely missing, and we cannot be sure about the identity of the doctor or the patient. The asynchronous telemedicine consultation occurs via email, fax, recordings, etc. These are the modes to transfer the data, documents, test reports, or a second opinion may be given, and no separate infrastructure is required. These are not a real-time interaction, and patient identification is document-based only, difficult to confirm, and delays may be there as doctor may not access at the same time or may access at this own convenience. So it's very important when doing the wound care for the diabetic foot patients to segregate them into limb and life-threatening and compared to those with only limb-threatening infections. So almost all patients of diabetic foot can be triaged via teleconsultation except the critical or the priority 1 category patients. The positive impact of TM on triage is that it reduces the hospitalization and the need for frequent follow-ups. It is, the most important is it distinguishes the limb and life-threatening from non-limb threatening infections. And basically we use the asynchronous or synchronous transfer, it helps in management or streamlining the wound care plan. So this is the critical or the priority 1 urgency wounds, where there's such as the acute, chronic, or acute or chronic limb-threatening or life-threatening infections. The patient has systemic involvement, and it's a grade severe and some moderate infection, gas gangrene, sepsis, acute limb-threatening conditions, or acute ischemic conditions may be there. And these are the priority 1 cases, very difficult to triage, very difficult to manage. And second, priority 2, 3, 4, they can be managed. And these are the serious infections, as we can see in the picture. They're mild to moderate infection, and the one of the foot is developing. There's a blackening in the previous ulcer, ischemic patch is occurring, and there's a bulla which is occurring, and it may go into priority 1 case if not managed at the point. So it's a limb-threatening ischemic infection or spreading necrotype, spreading type of infection, worsening foot ulcers, dry gangrene, active Charcot foot, all are under this category. Now, the very few percentage, it's a priority 3, improving foot ulcer, inactive Charcot foot, the mildly infected, uninfected cases, neuropathic lesions, then the inactive Charcot foot. These are the cases which can be managed by telemedicine. The priority 4, where the almost heal ulcers or the uncomplicated venous leg ulcers, inactive Charcot, these are or diabetic foot risk assessment, neuropathic ulcers. All these are, they lie in the priority 4 group, and home telemedicine may be enough to manage them. So this was a study done in 2020. Both the studies were done, and they concluded that telemedicine and DF triage system, they go hand in hand, and remote along with the remote monitoring of the DFU patients to have a lavage of the to have a foot salvage at home comforts with the telemedicine, especially in the COVID times. Podiatric care is associated with fewer diabetes-related amputations, reduced hospitalization, length of stay, and cost cutting will be there through telemedicine. So, how does telemedicine actually work in the wound care? Telemedicine actually allows us to treat patients anytime, anywhere, at any distance, and develop a wound care plan, order wound care supplies, dressing supplies, or the other drugs. It can be done utilizing a smartphone, video camera, electronic medical records to store and exchange medical information. And it helps us to connecting to the home health nurse, staff, trained nurse, wound care nurse, or the health worker. And they can send the digital wound images, impart health education to the patient, and also help us in the wound assessment by showing the depth of the wound. So the doctor or the RMP can collect information from the wound care nurse through telemedicine. Now the various guidelines for the DFU diabetic foot ulcer specialist in patients who are without active wounds. So the patient may have complaint of pain, swelling, erythema. If the patient is complaining of pain, it could be ischemic or a neuropathic pain. If it is ischemic, it can be acute limb ischemia or a chronic limb ischemia. If it is acute limb ischemia, there will be 5 signs. The 5 P's: cold color, there will be pallor, pulselessness, painful limb. So, and there will be loss of function of the limb. So it needs, it's an emergency situation, needs urgent referral, life-saving measures or instructions, and facilitate referral of the patient as soon as possible to the vascular surgery emergency department. The chronic limb ischemia, the Doppler evaluation vascular surgeon consult may be needed. For the neuropathic patients, we do a neuropathy evaluation when feasible and rule out ischemia along with that, and give reassurance to the patient, footwear advice, foot care advice to the patient. The for the swelling, complaints of swelling, it may be cellulitis, it may be active Charcot, that is painless, painful foot. So for that, diabetic foot care specialist should be, consultation should be done in the clinic for total contact casting, and later on the specific other specific treatment for the active Charcot. For cellulitis patient, if mild and non-purulent and not spreading time, outpatient management with oral antibiotics suffices, and the patient should be kept under observation, or he has to be traced if it progresses moderate or becomes moderate or severe and worsens, then systemic antibiotics, hospitalization, limb elevation, and emergency procedures may be needed. For erythema or redness of the foot, if there is infection or there is inflammatory condition. So if it's infection or inflammatory condition, mild to moderate in intensity, we go for antibiotics, anti-inflammatory drugs. If severe, then we need a referral to a diabetic foot specialist, and maybe a outpatient debridement may be necessary, or emergency major surgery may be needed. So for the active wound, where there is a active wound is present already, then in these wound care, the telemedicine can also be practiced, and the uninfected, mildly infected, moderate and severe infections, we have the different line of management. For the uninfected class 1, it's a cases we give only the foot care advice and footwear advice. For the mildly infected cases, oral antibiotics, foot care advice, and a follow-up investigations may be asked for. For moderate and severe infections, they need evaluation by a diabetic foot specialist, wound care specialist, and patients with having added features or systemic signs of infection, they need referral to hospital with ICU facilities, and then the multidisciplinary approach to handle the situation. So telemedicine for the complex wounds, it works by, it's mandatory, and it helps in establishing the healing prognosis and needs an expert advice. It also helps in visualizing the life conditions at the home of the patient, in what condition he is lying, what is the condition, what are the surrounding conditions, what is the hygiene level, and how his dressing or his care is being done. And then tele-assistant with a village health worker or a caregiver for diagnosis of the wound depth, or a trained staff if he's present, we can do the ABPI measurements at distance and wound exploration to know the depth of the wound, and to decide about the peri-wound erythema, the color of the wound, exactly if it's not visible clearly. So they may assist the doctor in making a diagnosis on video consultation. Now, there are various smart technologies, wearable watches, mobile health technologies, sensor, foot mat with sensors for monitoring or noting the foot pressures, alterations in the foot pressure, sudden onset inflammation, temperature changes in the foot, to extend remission and improve the quality of life. And these wearable sensors, they can be tracked through the platform, and they can be, the nurse can help in giving the findings, or they may be the readings may be sent directly to the doctor prior to the consultation. So this is a video which is showing the home-based wound care by a trained nurse, and the wound is priority 3, where the wound is in the slightly improving stage, and I had an opportunity to talk to the patient, to greet the patient, strengthening my bond with the patient, and also visualize the ulcer and ask for signs if there is a smell or and to what material with which he can dress, and also see how is he dressing. Is he dressing aseptically or is not taking precaution? So all that can be supervised in home-based dressing. So this is another area where I could see the patient lying on the bed, and the wound I could see. So this was a healing wound, mid-foot amputation, which was being forefoot amputation, which was being inspected by me, and it was showing good progress. So it is helps in progressing the wound healing. Uh, uh, Video consultation can be an alternative to outpatient hospital care, and in the study, it reported that the experts, it's possible for the expert to conduct clinical examination, decision making at a distance in close cooperation with the visiting nurse and the patient. Also, it adds to the confidence and the knowledge of the visiting nurse, and it's a learning situation offered to the nurse who's consulting from the home. So this is a foot expert, Dr. Vibhakar, who is consulting with the patient, consulting a general practitioner about the persistence of forefoot ischemia even after the angioplasty in this patient who had a left grade 2 gangrene and an ulceration. So this is possible with the help of the teleconsultation. And this was a wound where multiple consults or tele-expertise was needed. And in this patient, the patient, diabetic female on OHA, 8 months, she had a ulcer, swelling, pain, and a mild pain, and a blackish discoloration over the foot. And the pulses were palpable, good vascularity, X-rays were within normal limits. We did a complete excision, grafted it, and the biopsy report came out consistent with malignant melanoma. The graft was rejected. And so we did a consultation. The general surgeon contacted me, and Dr. Rajesh Priyavati contacted me, asked me that what should be done, whether should be regraft or should we go for a flap. I asked for a vascular surgeon consult, Dr. from Shyam Gupta, and he also said that we should go after a culture and improving the anemia of the patient. We should go for again regrafting instead of a flap. Similarly, this patient, as reported by the resident of the ward from the medical college, he did amputation of all toes for a 4-month old non-healing wounds over the foot, and the color Doppler was normal. The foot was showing the changes of infection. The counts were very high. The sugar was fluctuating. And the resident reported to me, and as he was asked, he wanted the foot expert advice, and he had done a improper debridement and amputation. So I asked them to go for a quick midfoot guillotine amputation, and they suggested the antibiotics, take deep tissue during debridement, and follow up with me and see the sugars, keep the sugar monitoring, and later once the deep tissue cultures are available, to go for the specific antibiotics. Here, a vascular consult was sought for a lady with a gangrenous toe, and she had a non-healing amputation fossa, and the SFA posterior angioplasty was done with good flow, and post-operatively the wound healed well. Sorry. So these are the day-to-day situations, and we are using the various mobile devices or telecommunication to treat the patients. So there are several advantages of telemedicine in wound care. We can access the remote areas, no appointment wait time. It can be done in the real time, streamline the wound care plan, resulting in decrease in the emergency department, cuts down the travel time and the cost of the patient. Health education bonding between the patient and provider can increase. And it helps us in early initiation of the wound treatment and monitor the progress of the wound. So the disadvantage may be the decrease in the in-person visits can lead to misdiagnosis. The palpation and the wound examination may be fallacious, or an added cost for the technology may have to be paid. There's a particular learning curve for the health worker, caregiver, or the patients. The licensing, reimbursement rules, etc., which make the whole thing very cumbersome and complicated. Then inability to detect odor and the healing touch is missing. The complex wounds may need a referral and a counseling, and it may be difficult to handle those complex wounds. It's meant basically for the healing or the priority 2, 3, 4 wounds. So Well, we all consultations we did were in accordance with the telemedicine practice guidelines. So this was added as an amendment to the IMC Act 1956, Professional Ethics and Etiquette Act of the IMC, and that all the registered medical practitioners are entitled to practice telemedicine, and all of them can continue to do so within the next 3 years of notification. Till they have done in that duration, they are supposed to do an online course which will be offered by the government. And to maintain the same professional and ethical norms as in the in-person consultation is a must for all these consultations. All channels of communication can be used, various modes of telecommunication may be used. So these telemedicine practice guidelines, they provide us the norms and the protocols to practice within safe limits. However, they do not mention about any specification about the hardware or software data management systems, and which to conduct surgical or invasive procedures remotely using a digital technology is not allowed. Even international consultations are not allowed, and research and evaluation, continuing education of health workers are not dealt with in these guidelines. So the key elements, 7 key elements in the telemedicine guidelines are the telemedicine should be appropriate and sufficient as per the context, as per the, it is for the discretion of the RMP to decide whether there is a need of telemedicine, and if it is in the interest of the patient's condition, after taking a holistic view of the patient, and only then he should go for telemedicine consultation. Then identification of the registered medical practitioner and patient is needed. So both have to identify themselves, and registered medical practitioner has to display his registration number with the Medical Council India, and on his prescription, on his letterhead, in his profile on WhatsApp, or any tab he's using, or any modality he's using. He's supposed to, and also during the consultation, he has to introduce himself to the patient. The patient also needs to put his registered ID, and also give complete address, name, age, contact number, etc. They have to be completely, a complete identification should be there. The patient consent, if he tries to do the telemed consultation first, then the patient's consent is called as the implied consent. So this has to be, and the explicit consent is when the village health worker or the registered medical practitioner or the caregiver may start with the consultation. So this is the implied consent, and it has to be given in a particular format, and given as an audio, text, or a mail to the or maybe a visual by a video call which has to be preserved for a later date. The mode of telemedicine which may use may be audio, video, or text based, and any modality of these modalities may be chosen. It's entirely on the discretion of the practitioner to choose whichever mode which will be appropriate to ascertain the diagnosis. The exchange of information for patient evaluation, the RMP should gather as much information as possible through the digital records of the patient, to the history taking. If additional information is required, you can take the help of the caretaker or village health nurse, or another registered medical practitioner for during tele consultations. And after this information, he can decide on the whether telemedicine should be appropriate for the, and he can whether he needs a in patient consultation or a visual examination by another registered medical practitioner who is nearby the patient, or any other wound care nurse who is trained, whether they can do the examination for him. So anytime he feels his information that he's gathered is fallacious or is not enough, he can even await the consultation, or he can ask for a visual complete inspection and the visual examination of the patient. The type of consultation may be first consult or a follow-up consult. Patient management, health education, counseling, and medications are then prescribed. So when we talk of the first consult, it is actually the consultation which is occurring for the first time, and any consultation which was taken for another health problem prior to 6 months, or before 6 months, those are also be taken as a first consult. Follow-up consult, they are taken within 6 months of the first consult for the same problem. So after ascertaining the diagnosis with the help of the information, the RMP has to prescribe medicines according to the specified or the restricted list of the medicines. In the list, though, there are over-the-counter medications or the medications for emergency are used, and these may include the antipyretics, cough supplements, chloroquine, etc. may be used. For the list A, we use the first consult medication or in-person consultation medicines which are prescribed for the first time, and or by a video consultation or in-person consultation during the first, and then we can simply use these for the continuation or as a refill drugs during the follow-up medications. These drugs are also included in the list. In the list, we will include the add-on medications to the first consult during the follow-up consult. So these add-on medications, suppose the patient is on a particular medication not getting relief in the blood pressure, then we actually go for the another add-on of the another medication. The prohibited drugs like narcotics, psychotropic substances, they are absolutely restricted. They cannot be prescribed to the patient. So mostly the drugs prescribed had low abuse or the potential, or they are the safe drugs which are prescribed during telemedicine consultation. The emergency drugs or the injectable drugs or the drugs which are for emergency situations are not prescribed during telemedicine consultation. Prescription is issued at the end of this, and the RMP usually provides a photo scan or digital copy of a duly signed prescription or an e-prescription to the patient by email or any other messaging platform. And directly, if he wants to transmit the pharmacy, he has to take the patient's consent. So the RMP has to abide by the medical ethics. He should upkeep and practice the medical ethics data and maintain the data privacy and confidentialities. Any misconduct on his behalf, like insisting the patient on telemedicine, or even when the patient can travel, misusing the patient data, prescribing drugs from the restricted, from the specific restricted, not prescribing drugs from the list, or providing the prohibited list, and then soliciting the patients for telemedicine through any other advertisements or inductions. These are all amounting to penalties and punishment. And moreover, he should maintain a document record. His teleconsultation call logs all have to be maintained. Even the prescriptions, pharmacy prescription or the consultation records all have to be maintained by the registered practitioner, and he has also to maintain the confidentiality of all these records. So there are certain guidelines for the platforms which connect the providers with the patients or the village health worker or any other person. Then these guidelines, they also provide, give the correct identity of the practitioner, the patient, and the failure to address the customer grievances can be reported to the BOG, to the Board of Governors in supersession to MCI, who may take appropriate action and may even blacklist the platforms. Use of artificial intelligence or machine learning is not allowed to counsel or write any medications, and this is also amounting to the reporting the same to the BOG. For telemedicine fees, as displayed on the profile of the RMP, and as the just appropriate fee as for the in-person consultation, same is charged by the for the process of consultation by the registered medical practitioner, and he should give an invoice or receipt for the fee, and he should preserve these invoices for a record. So the legal implications of medical or the medical malpractice litigations, they come when the duty of, there's a breach in the duty of the care and medical liability comes up, or the confidentiality is not maintained in the doctor-patient relationship. As we have just discussed, the records are not maintained. There's a leaking of the privacy at the consultation process, prescribing restricted drugs, as we have just talked about. All these amount to legal malpractice, and special responsibilities of Board of Governors in supersession to the MCI. They say that the drug list can be amended from time to time. Also, the guidelines are subject to amendment from time to time in the larger public interest with prior approval of central government of Ministry of Health and Family Welfare. And the RMP has to be keep himself updated on the process. Now, the process of teleconsultation can occur in the 5 scenarios. When patient talks to the registered medical practitioner or caregiver or health worker talks to the RMP, or there are emergency situations. So the first consult we've already discussed, when the patient is consulting RMP for the first time, or he has consulted earlier but beyond 6 months, and or for a different health condition, and patient consulting the RMP within 6 months. So there are the pre-consult process, there's during in-consultation process or the post-consult. Pre-consult, we actually book the appointment for the patient and the regarding the teleconsultation process. So during in consultation, the reminders go and the patient complete consultation process is being taken, and the post consultation where the prescription is delivered to the patient. So during the booking appointment or booking process, the doctor shares his profile page link with the patient through a cloud-based technology on the Google, where his app is there, or through an app, or through where his profile is displayed, and patient or doctor also will book the either of them can book the consultation. After taking the consent of the patient is taken to the payment gateway, where there are several options, and patient after that patient uploads his record in advance of the consultation, and the consultation process may be initiated later on. Once this payment is completed, the doctor gets a reminder mail that the patient has made the payment and is going to deposit his record. So doctor schedules the appointment, and this appointment can be adjusted between the doctor and the patient convenience. Once the appointment is fixed, then the reminder is sent to both of them, and the patient may connect, RMP may choose his own modality of connecting with the patient, and they confirm each other identities after giving consent for the procedure and identifying themselves. So the caregiver may be asked to send the photo records before, and in that the specifications are that it should be from 3 different angles with flashlight on, and one of the photos with both feet together for comparison. So this has to be told beforehand, so that the data, so the patient attendant or the patient gives photos accordingly, and the videos of wound can be provided from the previous records. So, and patients inquired about the history of the various wounds present, or the symptoms, fever, pain, erythema, discharge, any symptoms, COVID symptoms, because it's the COVID times, and sugar levels, and also the caregiver or the health workers can potentiate these information, and if the patient is febrile, maybe the temperature record may be there. Now, this primary consultation can end in 3 ways. The clinician, number one, clinician will request a lab investigation, reschedules the consultation to review the reports, writes the medication, and the consultation is over, or he sends the patient for emergency referral if he finds that the examination, the information gathered reveals that the patient's condition is very critical or serious, and the wound is deteriorating, and it's a life-threatening situation, limb-threatening, demanding hospitalization. So life-saving measures are given, patient is counseled, and referral to the higher center is done. Second way is clinician may request the patient for in-person consultation, because he may need to further reach his diagnosis through added informations. Then if the clinician is, however, convinced about that the wound is healthy and he does not need any major treatment, need not attend the hospital, then the patient is simply given health education, minor and this counseling may be given regarding the foot care, and along with the specific treatment for the wound. So simple antibiotics may be prescribed for the wound cleansing and the dressings, non-adherent dressings. Patient should be instructed during the consultation also about the twice daily foot care, use separate indoor-outdoor footwear with socks, watch for danger signs, presence of callus, fever, reddening, any warmth or blister, and clean their wounds daily and apply the simple non-adherent dressings. I usually provide small videos to the patient, upload them on their mobile sets, so that the patients can watch them and can do that. Also, the foot care can be uploaded on their mobile, so that they can keep on seeing the foot care and do at their homes, and provide mental health support if they are not feeling are they feeling depressed with their wounds, or chronic non-healing ulcers, or the COVID times where they're in the lockdown period. So all this, and additionally they have to use the COVID protection guidelines, because the COVID pandemic is also going on, especially for the patients who are on immunosuppressants or who are having added comorbidities. So a word of caution in telecommunication is we have to ensure the safety of the teleconsultation conversation, as there may be a leak, especially during the leak of privacy, and leak of data may occur. Patient data has to be safe and secure, and record of teleconversation should be maintained. To summarize, telemedicine, definitely it has emerged as an enabler technology, and the various strategies can be applied to for the healing and monitoring of the diabetic foot wound patients by the wound care specialists in patients from remote and rural areas or in the home care settings or the nursing home settings. And almost all cases of diabetic foot wounds can be triaged except the priority one or the critical patients. The digital wound image sent by store and forward approach by the trained nurses, giving them instruction how to take the photograph, and video consultation. They help assess they plan the wound curriculum, and maintain the continuity of the treatment. So telemedicine practice guidelines, they provide the norms and protocols for safety and security of the teleconsultation process. So well, in this picture where Dhritarashtra and Sanjay are sitting, the Dhritarashtra was blind, and Sanjay is acting as a telecommunication device to convey his or verbally narrate his visual perceptions occurring at a distance. So this is probably the earliest telecommunication device. Thank you so much for the patient hearing.
Thank you, Manisha, for a very lucid presentation on the role of telemedicine, particularly pertaining to our COVID pandemic and the management of diabetic foot patients. Now we go to that interesting part of question answers. I think there's only one question which has come up. Dr. Munna Sherpa has asked, is psychiatric consultation allowed in telemedicine?
Well, when the patient is minor or the patient is mentally or physically handicapped and cannot accompany, patient may come accompany, maybe there during teleconsultation or may not be there, then the caregiver or the village health worker with the authority letter and his age proof and ID proof can uh, do the teleconsultation on his behalf. So this is the practice which we do, because the psychiatric and also if the patient needs a psychiatric evaluation, teleconsultation during the teleconsultation process, the usually the relative would be present, and he should also give his proof. And the teleconsultation can very well occur. In fact, it's a very widely used modality. Teleconsultation is very widely used modality.
So
In
can
the patient.
Can antipsychotics be prescribed through telemedicine?
So if the first consult is an in-person consult or a consult where the video consultation has been done, then the RMP is very much, and RMP has also seen the various records. Then in the first consult itself, he gives a prescription where he prescribes the antipsychotic drugs. So as an add-on, if those antipsychotic drugs are not working, then from the list B, add-on drugs can be there. If they are not working, they can be given. However, the drugs which have abuse potential, psychotropic with abuse potential as a new add-on should be avoided.
Right.
Yeah.
My personal question.
Yeah.
I go through, I think that Dr. Juzair Ali has asked a question. How can how doctor can ensure privacy?
Yeah, to ensure the privacy, he has to use a very good platform, and he should be sure about the authenticity of these platforms which are connecting them. And on his behalf, he can keep the data very safe and secure, and do not share it with the others, as it is punishable for him. And also, however, if there is any breach or leakage from the side of the patient or any other person, then it is the RMP is not liable for that. But in this way, he can maintain the privacy. The teleconsultation call from an authentic call, or from a safer site, using a safe video consultation site can be done. Safe modality can be done. It's better to go for paid sites sometime, because there will be, of course, in telemedicine, there's a danger of hackers who may leak the consultation process. That is always lingering.
Dr. Manwar Ali has asked, is a wound care nurse a must for wound evaluation? What if you don't have a wound care nurse to do your telemedicine?
So when the wound care nurse is not there, Then usually, as I told you in my case, what I already, when I operate a patient or treat a patient, I give them pre-dressing videos, or do the dressing and take a video on the same patient and upload on their mobiles, so that when they are doing the dressings, either they connect to me, even if he has certain ideas, or the home, or the person who is not a qualified nurse and is doing the dressings, he can see the video and do it. It's an instructional video where I am myself giving instructions, or he can uh, do as instructions which I am giving. So this can be done, because many of the patients are villagers, they are doing the dressings, relatives are doing the dressings, they are not there are no wound care staff which are uh, well trained, and there's a shortage of such people. Even wound care, they do not have any training. They may be simple Anganwadi workers, or a person, literate person living nearby, they can do the dressings. So these instructional videos which I upload may help the patient. So we must equip the patient with such information, and we should upload them as a part of the patient education or giving added information. So these are add-ons to the these telecommunication services which can be given by us.
So
It's
just to
called
add on,
telehealth actually.
just to add on, in our set of patients who have been admitted and operated for a foot infection and they go back and need dressings, we do make the attenders do the couple of first one or two dressings when they are still inpatient. We teach them how to do in remote places. So the answer to the question is, a wound care nurse is not a must for evaluation. An educated or any patient relative or caregiver at home is sufficient enough with some amount of common sense. So next question is, proxy is possible in teleconsultation question. Dr. Dhananjay Kumar has asked this question. I believe, I'm not sure whether he meant to can somebody dupe in for a consultation. That is, if the wife is suffering and the
Yes.
husband
Hello.
can
Yeah.
consult you.
Certainly, as I said, he has to have a authority letter, or during the first consultation itself, he identifies through presents ID proof, and he said that I can take follow-up consults with this ID and with this authority letter. So at the time of consultation, he can produce this to the RMP, and the relative can very well communicate with the on behalf of the patient.
So any free apps available for wound size assessment which could be useful in telemedicine, especially in this pandemic scenario? Any free apps that you would suggest for wound size assessment?
Yeah. Well, there are for wound care. You mean
For
apps for telecommunication for doing the
any no
teleconsult?
no 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 any free apps available for wound size assessment?
Yeah, there are many apps which can be seen on along the internet. It's flooded with that, and they can measure the dimensions of the wound, and they can also tell about the depth of the wound, and provide with the good photographs compared to what is taken. And so the wound photographs will be good. The wound dimensions can be taken, and we can have a better look at the wound. So these apps, they are certainly very helpful, and they can provide this information. Lot of such apps are available.
Right. Now, Dr. Sudhir Jain, our friend from Assam, has sent, on a lighter note, telemedicine appears to be more useful for a physician of a diabetic foot management team rather than a diabetic foot surgeon mostly busy with critical cases in the OT of a tertiary center. Second, a retired diabetic foot surgeon may probably be a better person to engage in telemedicine on full-time basis. Third, telemedicine may be useful in diabetic foot field if we develop robotic services simultaneously.
Well, regarding robotics, I have already mentioned telemedicine practice guidelines do not advocate the remote perform surgeries. They do not, they have not explicitly, they have completely excluded this. They are not included in these guidelines. So certainly we cannot do and do a telemed. These are the confidential things. Then the other thing is that it's not only for the retired person to do telemedicine. That's a wrong concept. If I have operated a patient and I cannot keep a track of the patient after certain dressings, the patient's going home, then what is the use? And worsens, the patient returns again, and I had no track, and no advice was given by me, and I did not maintain a bond with the patients. So this telemedicine helps you to reach out to the remote places, newer patients across the all across India. You can reach out. Also to maintain the continuum of the, you can monitor the wound progress yourself. You don't need a staff to do that. Yeah, certainly a surgeon would be very much anxious to know how the wound is doing and how the wound is being taken care of. So it is not only for the senior or the some senior surgeon or retired person to do a boredom job of boredom. So it's a very important job. And during when you are not having the staff, or when you are the times when you are not doing consultation, then in your OPD, then you can also do consultations from the home. So and it is also on the part of the of the wound care specialist or any RMP that they can refuse a consultation if it's coming at the odd hours. So as per their convenience, they can give consultation anytime other than their free time, and through a teleconsultation, and it is also chargeable. So anyway, they are earning even when they are not in the OPDs by giving consultation. So this is not a retired practice.
Right. Mahesh Srinivasan has asked, Doctor, does DFSI have any standard program for training the nursing staff?
Well, they are developing this program, and for training the podiatrists, the special course is being run at the Amrita Institute, even by the at Maharashtra. Dr. Arun Bal is running this course, and Dr. Aarti Sharde and Dr. Sunil Kari also involved in this. Then at the and these they are providing these trained nurses to go into across India to give their services. So this training, a step-by-step project was also there to train the nurses, and the wound care nurses are also being trained. They have meet the minimum qualification of 12th intermediate, and if they are having and or if they are working with some doctor who is a qualified wound care specialist for past many years, then these wound care nurses are this experience is more important, and they can be this experience can be added to the qualification.
Okay. The next one is, if you could please list out a few names of the apps for wound measurement.
Well,
I don't personally use, whether I don't know
even
if
I
you are
don't.
used.
No, even I am not using. But then there are certain through the certain cameras we can mark the distances, and also the wound scales are available. So the through or even the gauze piece, sterilized gauze piece that can be stretched out, which is sterile thing, can be stretched out on the wound by the wound care nurse, and it can be shown. And that same thing can be kept over the paper scale, and it can be measured. So even they are even better than apps, because the technology part or the learning curve for the using these apps is still very it's going to be it's going to take a long time for them to become experts in India to use these apps.
Dr. GBKS Prasad, to all the panelists and attendees, it was a wonderful presentation. For telemedicine to be successful, the registered medical practitioner at the PHs needs to be educated, and steps need to be taken by government or healthcare agencies in that direction. Okay.
Thank you, sir. Thank you so much.
My personal question, Manisha, will be, many a time I use an app which is I practice with one of the corporate hospitals here. They have an app of their own. So following the same principles that you said, the telemedicine guidelines, many a time I see that my patients call me from Bangalore when I practice in Hyderabad, or from say Chennai. What, do you also come across? Because I think all through your presentation, I just heard in one place that as per the current guidelines, you are not supposed to give an international consult.
Yes.
What about across the state borders? Does it make a difference?
No,
With
no.
the one,
The license is for practicing all across India, but it is not, it's not, the current guidelines are not mentioning as of now about the practice across the outside India. So they are not mentioned. It's not, they have excluded. It's in the exclusion.
so I think, thank you, Manisha, for a very wonderful presentation. We have answered all the questions which have come in.
Thank you.
Thank you all.
Thank you, Srinivas. Thanks a lot.
Yeah, madam. Very good.
Thank you, sir.
Very nice.
Better than that, didn't
As such, you have please skills you now.
Thank you, sir.
Let's
I'm just ending now.